All right. Hope everyone's as relaxed as I am right now. Thank you for that. So I kind of changed this a little bit to do more on genitourinary updates. This year ASCO and ASCO GU was more updates in overall, more than rather just bladder or prostate specific. So some key things to just kind of highlight. So some of the objectives that we're going to talk about are the abstracts. The first one is everolimus for kidney cancer in the adjuvant setting, so it's the EVEREST study. The second one is an update for adjuvant pembrolizumab post-nephrectomy renal cell cancer. It's the expanded efficacy analysis from KEYNOTE-564. Pembrolizumab plus axitinib versus sunitinib based on the KEYNOTE-426 study, which was presented a few years ago. This is looking at PFS2. A little bit on health-related outcomes and quality of life in advanced renal cell cancer, long-term outcomes in bladder cancer based on the Enfortumab Vedotin data from EV301. And then the last abstract is kind of the newest target in prostate cancer using lutetium PSMA, comparing it to cabazitaxel based off of cabazitaxel on the therapy trial. So these are the current targets that have been looked at in kidney cancer in general. So in the adjuvant setting, several different targets have been looked at, specifically the VEGF immunotherapy. And we actually use a lot of these targets now as part of first-line therapy or even second-line therapy. And EVEREST is the first study that looked at mTOR as a target in the adjuvant study itself. So these are just highlighting different mechanisms that have been looked at in renal cell cancer so far. So it's the mTOR, checkpoint, VEGF, and transcription factors that have been evaluated. So the current guidelines for adjuvant therapy for adjuvant therapy in renal cell cancer is for stage 2 or stage 3. So for stage 2 high-risk patients with grade 4 tumors with or without sarcomatoid features, adjuvant pembrolizumab is recommended. And for stage 3, it's clear cell histology, adjuvant pembrolizumab, or sunitinib, which is the category 3. And for non-clear cell histology, it's really surveillance or clinical trials. So these are all the adjuvant studies that have been done since the early 2000s. All the ones in the red have been negative studies, and the one in the green have been the positive studies. STRAC was the one that was published back in 2017, 2018, which showed that sunitinib in the adjuvant for high-risk patients could potentially be of some benefit, but it didn't really uptick, or it wasn't really utilized as much at that time. KEYNOTE-564 was the immunotherapy trial using pembrolizumab for high-risk patients and was shown to be beneficial and now is currently recommended. So EVEREST is the first study that looked at using an mTOR inhibitor for patients with high-risk relapse disease. So this was patients that were fully resected kidney cancer within 12 weeks. They had either a radical or partial nephrectomy, and they had PT1B grade 3-4, or PT2 to 4 with any grade or any node positive. They could have had clear or non-clear cell disease, no metastatic disease with an ECOG performance status of 0 to 1. And they were randomized in a 1-to-1 fashion of everolimus 10 milligrams daily times 54 weeks, or placebo daily times 54 weeks. And the patients were risk stratified based on intermediate high risk versus very high risk, as well as histology clear cell versus non-clear cell. When you look at the recurrence-free survival, it seems like there's a benefit, but it did not meet the pre-specified statistical significance. This is recurrence-free survival at the entire population. When you look at it with the very high risk versus the intermediate high risk, it seems like patients who had a very high risk may derive some more benefit compared to those with the intermediate high risk. Unfortunately, the adjuvant everolimus did not improve overall survival when you look at the entire population. So at the present time, adjuvant everolimus is not recommended for patients who have high risk or intermediate risk kidney cancer. So KEYNOTE-564 is looking at pembrolizumab in the adjuvant setting. This is looking at an updated analysis. So KEYNOTE-564 was patients who had grade T2, or T2, grade 4 sarcomatoid differentiation, any grade T3, and post-nephrectomy T4 lesions or node positive. They were randomized to either pembrolizumab or placebo, and the primary endpoint being disease-free survival per investigator, and the secondary endpoint being OS. So here they were looking at time to subsequent therapy as well as time to second progression based on randomization cutoff of 30 months. This is the distant metastasis-free survival when you look at pembrolizumab versus placebo. Pembrolizumab did do better at 80.1%. This is the time to subsequent anti-cancer therapy, which also showed an improvement. And this is time to second disease progression, or PFS2, and this also showed showed a hazard ratio of 0.57. So the current guidelines actually do, just to kind of go back to it, do recommend adjuvant pembrolizumab for grade 4 tumors with clear cell histology with or without sarcomatoid for stage 2, and for stage 3, adjuvant pembrolizumab or surveillance or sunitinib for stage 3. What's interesting is, though, last week we had a press release from Checkmate 914, which was using nivolumab and ipilimumab, and as a negative study for patients with moderate to high-risk patients. It's going to be kind of interesting to see what that data shows and how that may change this. That trial had 2 different cohorts to it. So it was we only saw the results from cohort A, which was the doublet immunotherapy. We have not seen the cohort B yet, which is monotherapy nivolumab. So that is yet to come. So this adjuvant therapy is probably going to change again sometime in the future, is what it seems like. So how do we actually risk stratify these patients with advanced kidney cancer? IMDC criteria has been used for a long time. It's the International Metastatic RCC Database Consortium. It's based on 4 laboratory features and 2 clinical features. And when you look at how do these patients fare over a period of time, there's actually a big stratification when you look at their overall survival, whether they're favorable, intermediate, or poor risk disease. So these are there's actually 5 frontline therapies that are approved for renal cell cancer right now, but 4 that are more commonly used. The one that's not listed is avelumab plus axitinib. But when you look across the board, all these tumors all these treatment options tend to be relatively similar, some better than others, depending on how you slice and dice the data. So what happens after first-line therapy? So KEYNOTE-426 was the trial that looked at pembrolizumab plus axitinib versus sunitinib in first-line stage 4 kidney cancer in patients who have never received any previous therapy, had measurable disease. These patients were stratified based on favorable and intermediate risk, and the primary endpoint being OS and PFS, and the secondary endpoint was ORR as well as duration of response. And the post hoc exploratory analysis was looking at PFS2, and this was presented by Tom Powles at ASCO, looking at subsequent therapy and PFS2 data. So what exactly is PFS2? So PFS2 is looking at progression-free survival from response to subsequent therapy. So the PFS is what we've seen before, and so this data is looking at PFS2. So this was the actual study design. So 861 patients randomized, 432 received pembrolizumab and axitinib, 349 discontinued treatment, 204 received subsequent systemic therapy, 64 favorable IMDC risk, 140 with intermediate or poor risk disease. And when you look at the first subsequent therapy, the patients that were on the combination arm of pembrolizumab and axitinib, most of these patients went on to receive any sort of VEGF or VEGFR inhibitor. When you look at the sunitinib arm, most of these patients received some sort of PD-1 or PD-L1 inhibitor, regardless of risk stratification. This is the PFS2. When you look at the favorable risk versus the intermediate and poor risk, at every time point, whether it be at 12 months, 24 months, 36 months, the combination therapy of pembrolizumab and axitinib tends to do better comparing it to sunitinib. So what does it actually tell us? The long-term results of KEYNOTE-426 continue to support the use of pembrolizumab and axitinib as standard of care for patients who have previously untreated advanced RCC. PFS2 was longer in patients who've had pembrolizumab and axitinib comparing to those with sunitinib, regardless of the IMDC risk. And then the results from this exploratory analysis really do support the long-term benefit of pembrolizumab plus axitinib for first-line therapy for patients with advanced clear cell renal cell carcinoma. So there has been a recent update to the NCCN guidelines for advanced renal cell carcinoma. One of them being tivozanib, which has been moved to a Category 1 recommendation for patients who have failed first or second line therapy, and that's based on the TiVo-3 study. The other recommendation is actually belzutifan, which is actually recommended for patients who've had VHL syndrome as another option of therapy. So there is some association between health-related quality of life and clinical outcomes in patients with advanced renal cell cancer. This was actually looking at data from Checkmate 214, which was presented back about 2017. So Checkmate 214 actually demonstrated overall survival and progression-free survival in long-term follow-up in patients who received nivolumab plus ipilimumab, comparing it to sunitinib. And so this is actually showing health-related quality of life benefits in this long-term follow-up. Prior studies have shown this in kidney cancer and other malignancies. Here, the authors were really looking at to figure out if the health-related quality of life inform on risk of progression or death in patients with renal cell cancer. So the objective was to use this 5-year follow-up data in the intermediate and poor risk patients and to assess the baseline health-related quality of life in PFS, baseline health-related quality of life in OS, and compare it to a longitudinal health-related quality of life for both PFS and OS. And the baseline is collected pre-treatment and at randomization, and the health-related quality of life is collected after randomization while they're on study. And they used the FSCI-19 score, which was using 19 score as well as the disease-related symptom physical subscale. So this was the actual study design of Checkmate 214. Patients had advanced RCC, which were untreated, had a KPS of 70%. They were randomized in a 1-to-1 fashion of receiving nivolumab and ipilimumab. Nivolumab 3 milligrams per kilogram, plus ipilimumab 1 milligram per kilogram every 3 weeks for a total of 4 doses. Then Nivo 3 milligrams every 2 weeks. Versus sunitinib, 50 milligrams once daily for 4 weeks, 2 weeks on, or 4 weeks on, 2 weeks off on a 6-week cycle. This was the actual FSCI-19 instrument that was used. So the disease-related symptoms, they were looking at lack of energy, pain, weight loss, fatigue, shortness of breath, fever, bone pain, cough, et cetera. Some of the treatment side effects, nausea, diarrhea, side effects, how it was interfering, functional well-being and emotional well-being. And so on the top, you can see the baseline scores, and on the bottom, you can see the total score as well as the disease-specific score as well. It seems to be pretty significant. And when you look at the overall scores and the scores in comparing it to survival, there seems to be a relationship as well. The lower HR indicating a stronger association and a greater improvement from death. And this is the actual risk reduction. It's showing about the FSCI-19 total 31% reduction in risk of death if there's a 5-point improvement in the total score, and a 35% reduction in death if there is a 4-point improvement in the disease-related symptoms. So it really just suggests that there's a stronger association between longitudinal quality of life scores and OS comparing it to the baseline quality of life and OS. So really, it just suggests that better health-related quality of life scores were associated with the longer PFS and OS, and a stronger association was suggested for longitudinal health-related quality of life and OS compared with the baseline. And it kind of just highlights the value of patient-related outcomes in measuring quality of life and prognostic modeling. In bladder cancer, there was an update for Enfortumab Vedotin for patients who previously treated advanced urothelial carcinoma. 5-year survival rate for metastatic bladder cancer is around 8%. So Enfortumab Vedotin is an antibody-drug conjugate against Nectin-4, previously demonstrating an overall survival and progression-free survival in patients with advanced and metastatic UCC. And this was the confirmatory phase 3 EV301 study. So patients were randomized in a 1-to-1 fashion of Enfortumab Vedotin versus pre-selected chemotherapy of either, whether it be docetaxel or paclitaxel or vinflunine, and the primary endpoint being overall survival. This is looking at secondary endpoints of progression-free survival, disease control rate, and overall response rates. So when you look at the overall survival, it seems to hold, the top line being Enfortumab Vedotin and versus chemotherapy. The median seems to be 12.9 months versus chemotherapy of 8.9. The progression-free survival is similar, Enfortumab Vedotin being 5.5 months versus chemotherapy of 3.7 months. And then when you look at the safety and tolerability, there was no new safety signals that were noted in the longer-term follow-up. Top adverse effects being alopecia, peripheral sensory neuropathy, pruritus, fatigue, decreased appetite, and diarrhea. And I think I have like 4 minutes left, so I'm going to finish one more abstract. So in conclusion, so after 2 years of follow-up, EV did have a significant OS compared to chemotherapy. PFS and ORR were consistent with what was noted in the interim and the final analysis, and the safety and tolerability were consistent with findings from the interim and the final analysis as well. No new safety signals were noted. So in my last 3 or 4 minutes, I'm just going to talk about lutetium, LU177 versus cabazitaxel in patients with castration-resistant prostate cancer progressing after docetaxel after a median follow-up of 3 years. So lutetium is now FDA approved for patients post-taxane, post-ARI, who have a PSMA study and are showing some expression based on the VISION study. Now this is comparing lutetium versus cabazitaxel. So this is the therapy trial schema. Patients had to have MRCP post-dose docetaxel, rising PSA, and a PSA of greater than 20. They had to have a gallium PSMA PET with FDG PET CT, an SUV of 20 at any site, and it was centrally reviewed. So they were randomized in a 1-to-1 fashion of either receiving LU PSMA 617 IV every 6 weeks for up to 6 cycles, or cabazitaxel 200 milligrams per meter squared Q3 weeks for up to 10 cycles. And this is how the study design was, the primary endpoint being looking at PSA reduction. And when you compare it to cabazitaxel versus lutetium PSMA, and then the secondary endpoint being progression-free survival and objective response rates. In the troublesome adverse effects and patient-reported outcomes, grade 3/4 toxicity was around 53% in the cabazitaxel versus the LU PSMA was 33%. The progression-free survival was 3% at 12 months was 3% at cabazitaxel, and PSMA was 19%. And the ORR for cabazitaxel was 24% versus lutetium was 49%. This is the actual PFS data looking at cabazitaxel versus PSMA 617. There's really no difference, and there's no difference in overall survival in patients receiving LU PSMA versus cabazitaxel. The hazard ratio of 0.97. So there is an AIM secondary endpoint of overall study, overall response. It's early withdrawal because patients may have decreased subsequent LU PSMA may have decreased the benefit of LU PSMA. So kind of in summary, for the EVEREST study, everolimus for renal cancer in the adjuvant setting, there's currently no role for adjuvant therapy for this. Adjuvant pembrolizumab still seems to be indicated for patients with high risk stage 2 and 3. We'll have to see how Checkmate 914 changes this data based on the negative trial for ipilimumab and nivolumab. PFS2 was longer for patients who've had pembrolizumab and axitinib compared to those in sunitinib. And health quality of related outcomes seems to have patients with longer PFS and OS. Enfortumab Vedotin did not show any new signals compared to chemotherapy even after 2 years. And then for the last trial for lutetium, overall, there does not seem to be a difference between overall survival in lutetium versus cabazitaxel, but the tolerability of lutetium seems to be slightly better. And I have 30 seconds to spare for any questions.